Good day! Our next topic is about the introduction to chemotherapy. We are going to cover the general overview, problems with the use of antibiotics, superinfection, and antibacterial agents. Chemotherapy is a therapy of infectious diseases and malignancy by use of chemicals called chemotherapeutic agents. This is defined as treatment of systemic infections or malignancies with chemicals selectively toxic to pathogens or malignant cells while sparing host cells. This has minimal or negligible effects on hosts and is also known as treatment for neoplastic diseases due to similarity between malignant cells and pathogenic microbes. Selective toxicity is essential for chemotherapeutics, targeting pathogens selectively based on variations in structural components or metabolic processes. Antibiotics are derived from microorganisms exhibiting selective suppression of other microorganisms at low concentrations. The word antibiotic is derived from antibiosis. This chemical substance is produced by microorganisms and suppresses the growth, multiplication, or may eventually kill the other microorganisms at a very low concentration. This may be antiviral, antibacterial, antifungal, and antiprotozoan. The antiparasitic drugs are ectoparasiticides and anthelmintic or antiprotozoan. Ectoparasiticides combat external parasites like lice, fleas, and ticks, while anthelmintics or antiprotozoan drugs target internal parasites such as worms and protozoa. Next is cancer chemotherapy. This is the treatment for malignancies using drugs. This targets rapidly dividing cells, including both cancerous and healthy cells. The methods for chemotherapy include chemotherapy drugs, radiation therapy, and surgery. Anti-cancer and antiviral drugs exert poor selectivity, impacting normal cells similarly to diseased cells. Most of the antibiotics exhibit a great degree of selectivity. The first is inhibit bacterial cell wall formation. These examples are penicillins and cephalosporins, exploiting absence of cell wall in mammalian cells. The next is inhibit bacterial protein synthesis. Examples are tetracyclines and aminoglycosides via specific binding sites on bacterial ribosomes absent in mammalian ribosomes. Next is bacteriostatic effect on sulfonamides due to PABA antagonism in folic acid synthesis. Mammalian cells utilize preformed folic acids. History of chemotherapy. The first is the ancient recognition of therapeutic agents. It started in the ancient Indian and Chinese medicine, recognizing therapeutic value of soil, plants, minerals, and metals. There's also treatment of syphilis with mercury compounds and malaria with cinchona bark. Rural folklore medicine recommends age-old remedies for carbuncles, boils, and infectious diseases. Next is the breakthrough in synthetic chemicals. Paul Ehrlich discovered bactericidal and antiparasitic activity of dyes, which is the methylene blue, and arsenicals, which is the arsenophenamine. He coined the term chemotherapy and introduced chemotherapeutic index. He won the Nobel Prize in 1909 and regarded as the father of chemotherapy. Next is Gerhard Domat. He discovered antibacterial activity of diprontonsil. This led to sulfonamides and popular antibacterials. He won the Nobel Prize in Medicine in 1938. Next is the demonstration of antibiosis. Pasteur and Joubert demonstrated bactericidal property of common bacteria against anthrax bacilli. They are the first to show phenomenon of antibiosis between microorganisms, basis of antibiotics. Next is the golden age of chemotherapy. Penicillin's discovery and impact in 1928. This is Alexander Fleming's accidental discovery. This is established as antibiotic by Florey and team during World War II. This won the Nobel Prize in 1945. Next is the expansion of antibiotic discoveries. Streptomycin was discovered in 1944, chloramphenicol in 1947, chlortetracycline in 1948, amphotericin B in 1956, cephalosporins in 1960, gentamicin in 1964, fluoroquinolones in 1980s. The ongoing search for new antibiotics continues due to pathogens becoming refractory to older ones. Classification of antimicrobial agents, or AMAs. Antimicrobial agents are synthetic as well as naturally obtained drugs that are used to inhibit or kill microorganisms. Antimicrobial agents are classified according to mechanism of action, type of organism involved, spectrum of activity, type of action, source of drugs, and chemical nature of the drugs. Based on the mechanism of action, the first one is inhibit cell wall synthesis. These drugs are the penicillin, cephalosporin, cycloserine, vancomycin, and bacitracin. The other one is causes leakage from cell membrane, which are the polypeptides and polyenes. Next is inhibit protein synthesis, which are the tetracyclines, chloramphenicol, erythromycin, and clindamycin. Cause misreading of mRNA code and affect permeability are the aminoglycosides. The ones that interfere with DNA function are the rifampin and metronidazole. Next is interfere with DNA synthesis are the idoxuridine, acyclovir, zidovudine. The interfere with intermediary metabolism are the sulfonamides, sulfones, PAS, and trimethoprim. The ones that inhibit DNA gyrase are the fluoroquinolones. This is an illustration of the different mechanism of actions of the drugs to the cell. Next classification is the type of organism involved. In antibacterial, these are penicillins, aminoglycosides, and erythromycin. In antifungal, these are the griseofulvin, amphotericin B, ketoconazole. Antiviral are the idoxuridine, acyclovir. Next is antiprotozoal, the fluoroquinine, pyrimethamine, metronidazole. The anthelmintic is the mebendazole, pyrantyl DEC. The antituberculosis is the isoniazid, rifampin, and ethambutol. The next classification is a spectrum of activity. These are the narrow, the broad, and expanded spectrums. The narrow spectrum has activity against either gram-positive or gram-negative organisms, such as penicillin and streptomycin. The broad spectrum has activity against both gram-positive or gram-negative. These are tetracyclines, chloramphenicol, and erythromycin. But now, extended spectrum penicillins, newer cephalosporin, fluoroquinones are now available. Also, some agents are capable of acting on bacteria, rickettsia, and protozoa. Another classification is a type of action. They can be bacteriostatic, which includes sulfonamides, tetracyclines, chloramphenicol, and erythromycin, or bactericidal, which are penicillins, aminoglycosides, polypeptides, vancomycin, and ciprofloxacin. Some static drugs may become cidal at high concentrations in urinary tract, nitrofurantoin, and sulfa, and vice versa. Another classification is the source of drugs. In fungi, these are the penicillin, cephalosporin, and griseofulvin. From bacteria, these are the polymyxin B, colistin, and bacitracin. From actinomycetes, these are the aminoglycosides, tetracyclines, chloramphenicol, macrolides, and polyenes. Next are the principles of chemotherapy. The first is selective toxicity. Drugs should selectively target pathogens or cancer cells without harming host cells. Chemotherapy should be rational and needs to be supported by either a clinical or microbiological diagnosis to identify the pathogenic organisms. Characterization of the pathogen, include its sensitivity to an AMA, is essential. Selection of an appropriate drug based on pathogenic organism, patient factor, and drug factor. If possible, it is better to use narrow-spectrum antibiotic, which is more selective and thus cause less interference with normal resident bacteria. The drug should be used in proper time, by proper route, at a proper dose rate, and for a proper duration. If an antibiotic is used, it is better to administer it as immediate as possible at a high dose for a shorter period of time and continue beyond 48 hours after disappearance of symptoms unless signs of toxicity are seen. This ensures that the organism is eliminated and there is less chance of developing antibiotic-resistant bacterial strains. Moreover, the antibacterial activity of a given dose of an antibiotic is inversely proportional to the number of bacteria present. Therefore, earlier the treatment so that there is more chance that the infecting organism can be caught in their early logarithmic growth phase. Attainment of effective concentration of chemotherapeutic agent for a sufficient period at the site of infection is very important. Specific and appropriate supportive therapy should be undertaken to overcome the infections. The selection of an appropriate antimicrobial agent for treating infectious diseases hinges on several factors, including those related to the infecting organism, patient, and the characteristics of the drug itself. When considering microorganism-related factors, two primary approaches come into play. First, a clinical diagnosis may provide initial guidance, especially when the pathogenic organism and its sensitivity are predictable. In such cases, the choice of AMA is based on the presumed diagnosis. However, in scenarios where the infecting pathogen and its sensitivity are uncertain, microbiological culture and sensitivity testing become imperative. This involves isolating, identifying, and characterizing the pathogen, along with conducting sensitivity testing to determine the minimum inhibitory concentration of the AMA. It's crucial to understand key definitions in this context. MIC represents the lowest concentration of AMA that prevents visible bacterial growth after incubation, while MFC denotes the lowest concentration for the fungi. Additionally, MAC signifies the lowest effective concentration of antibiotic at the infection site in vivo, typically around 1/10 of the MIC, and MBC indicates the lowest antibiotic concentration, resulting in significant decline in bacterial count in vitro. These parameters provide a comprehensive framework for selecting the most suitable AMA and determining the appropriate dosage regimen. Next is the animal-related factors. Age determines pharmacokinetic properties of the drug. Aminoglycosides are excreted slowly in old animals because of poor renal function, and therefore a full dose of the drug may cause toxicity. Newborns cannot metabolize and excrete chloramphenicol because of deficiency of metabolizing enzyme and cause fatal gray baby syndrome. Tetracyclines are contraindicated in young animals and children as they accumulate in developing teeth and bones. Next is the functional capacity of kidney and liver. AMAs with low margin of safety must be used very cautiously when renal and hepatic functions are defective. Drugs like cephalothin, cephaloridine, nalidixic acid, tetracyclines, aminoglycosides, amphotericin B should not be administered in renal dysfunction. On the contrary, erythromycin, chloramphenicol, rifampin should not be administered in liver diseases. Host defense status. Integrity of host defense plays an important and critical role in the final eradication of the pathogens, particularly when a bacteriostatic drug is used. Bacteriostatic drug will be less effective in very young, very old, and debilitated animals because of poor or impaired host defenses. Bacteriostatic drug can cure an infection in a patient with normal defense status or immunocompetent, but a bactericidal drug must be given in patients with impaired defense. Next is pregnancy and lactation. It is better to avoid all AMAs during pregnancy, particularly during the first trimester period of organosynthesis, unless it is very much essential because this may cause abnormality in the fetus. Next, drug allergy and idiosyncrasy. If there is any history of allergy of an animal to an AMA, then it should not be given in that animal. Antibiotics, especially penicillins, produce severe life-threatening anaphylactic reactions in man and sometimes in animals. Next is the presence of pus, blood, CSF, and tissue breakdown products. This interferes with the efficacy of many AMAs like sulfonamides, nitrofurans, and aminoglycosides, whereas these factors do not affect the efficacy of penicillins. Next is the location of infection. It determines the choice of AMA and route of administration. Presence of infection behind barrier, such as meningitis and abscess. Next is the effects of AMA on intestinal flora. Ruminants are highly dependent on the integrity of the ruminal microflora, and thus oral administration of broad-spectrum AMAs affects the normal flora and leaving the field free for growth and multiplication of pathogenic yeast and fungi, which results in acute diarrhea. Next is the drug-related factors. Sensitivity of the organism to AMA. An AMA to which organism shows high sensitivity is selected. Type of antibacterial activity. A bactericidal AMA is preferred over bacteriostatic in a patient with impaired host defense, in serious life-threatening infections, and when the infections are behind the barriers. Antibacterial spectrum. If characterization of pathogen is possible, then use a narrow-spectrum AMA which selectively inhibit pathogenic organisms only. When no guess can be made about nature of organism, then broad-spectrum AMA should be used to cover all likely pathogens. Superinfections should be borne in mind. Combination of AMAs. Inhibition of bacterial growth with combination of antibiotic is antibiotic synergism or potentiation, where their concentration is less than or equal to 25% of the MIC of each antibiotic acting alone. Pharmacokinetic properties. Penicillin G, aminoglycosides, and chloramphenicol in ruminants cannot be given orally and are given parenterally. Aminoglycosides cannot pass through the blood-brain barrier and are ineffective in bacterial meningitis, whereas sulfadiazine, chloramphenicol, cefotaxime, and rifampin can pass through the blood-brain barrier and attain high concentration in CSF and are the preferred drug in meningitis. Penicillin cannot readily pass across the pleural or peritoneal membrane, whereas chlortetracycline does the same readily. Ampicillin and erythromycin attain high biliary concentration and can be given in biliary tract infection. For the dosing, adequate dosing to maintain effective drug levels above MIC. The first is the initial dose. This establishes therapeutic concentration, and the maintenance doses, which sustain effective levels for duration of treatment. The route of administration uses IV for serious infections, oral for convenience, but is not recommended in ruminants. For toxicity, if a number of AMAs having similar efficacy can be used for treatment of an infection, the least toxic AMA is preferred. Penicillins, cephalosporin, and erythromycin are preferred over aminoglycosides, tetracyclines, chloramphenicol, and vancomycin. An AMA should have wide-term chemotherapeutic index. The risk of development of drug resistance among microbes and residues in the milk products, meat, eggs must be considered. The cost of AMA. A less costly AMA is generally preferred to expensive one without compromising the efficacy. Next are the problems with the use of antibiotics. Complications of antimicrobial therapy. Antibiotics have revolutionized medicine by treating bacterial infections effectively. However, their widespread use has led to several significant problems. First is the toxicity. Some drugs such as tetracyclines, erythromycin, and chloramphenicol can cause irritation and complications like abscess formation or thrombophlebitis when administered via injection. Various antimicrobial agents display dose-dependent toxicities toward specific organs. Aminoglycosides are ototoxic and nephrotoxic. Tetracyclines are hepatotoxic and nephrotoxic. Chloramphenicol causes bone marrow depression and aplastic anemia. Allergic and idiosyncratic reactions. Antimicrobial agents can trigger immune response like hypersensitivity reactions, ranging from mild skin rashes to severe anaphylaxis as they are foreign to the body. Common offenders include sulfonamides, penicillin, aminoglycosides, and cephalosporins. These reactions are not dose-dependent and are unpredictable. Next is superinfection. It is the development of a new infection in a patient due to the administration of AMA, especially broad-spectrum ones such as tetracyclines or chloramphenicol, or combinations of AMAs. These infections tend to occur more frequently in areas like the intestines, respiratory system, and urogenital tract. Next is the superinfection. Superinfection develops when an antibacterial drug intended for the pre-existing infection kills the protective microbiota, allowing another pathogen resistant to the antibacterial drug to proliferate and cause secondary infection. Microbial drug resistance. It is the insensitiveness of a microorganism to an AMA that were originally effective at treating infections caused by them. Vitamin deficiency. Use of AMA interferes with normal intestinal flora, particularly in herbivores, thereby impeding the synthesis of these vitamins. This may result in vitamin deficiency in man and animals. Antimicrobial resistance. It is unresponsiveness of a microorganism to an AMA, and it is similar to the phenomena of tolerance seen in higher organisms. When bacteria are no longer susceptible to the action of antibiotic, the bacteria are said to have developed resistance to that antibiotic. The types of resistance are the natural resistance and the acquired resistance. In natural resistance, some bacteria are inherently insensitive to certain antibiotics. In acquired resistance, it is when previously sensitive bacteria develop resistance to antibiotics. This can happen through genetic or biochemical changes within the bacteria. This is an illustration of how antibiotic resistance happens. In the first illustration, there are lots of germs and a few are drug resistant. Next is antibiotics kill bacteria causing the illness as well as a good bacteria protecting the body from infection. The third is the drug-resistant bacteria are now allowed to grow and take over. Lastly, some bacteria give their drug resistance to other bacteria causing more problems. Genetic change. Mutation. It refers to changes in the DNA sequence of bacteria leading to alterations in genes responsible for antibiotic susceptibility. Transmissible resistance. It is the ability of bacteria to acquire resistance to antibiotics through the transfer of genetic material from one bacterium to another. Transduction. It is the transfer of gene carrying resistance through the agency of a bacteriophage, such as virus that infects bacteria. Transformation. A resistant bacterium may release the resistance-carrying DNA into the medium, and this may be imbibed by another sensitive organism, becoming unresponsive to the drug. Conjugation. Sexual contact through the formation of a bridge or sex pilus. These are common among gram-negative bacilli of the same or another species. This may involve chromosomal or extrachromosomal plasma DNA. The resistance acquired by the bacteria may be exhibited in the following way: antibiotic inactivation by enzymatic breakdown, decrease in the affinity of the bacterial binding site, reduced antibiotic accumulation through development of active efflux mechanism by the bacteria, development of altered metabolic pathway, promotion of formation of dihydropteroate synthase with low affinity to sulfonamides but not to PABA, reduced uptake by the bacteria. Cross-resistance is the resistance seen among chemically related drugs. When a microorganism develops resistance to one drug, it is also resistant to the other drugs of the same group, even when not exposed to them. Example is the resistance to one tetracycline means resistance to all other tetracyclines. How to curb drug resistance. For clinical efficacy of an antibacterial, it is essential to prevent drug resistance. Following measures can be taken to curb the problem of resistance. A. Antibiotics should be only used when the clinical indications are clear. Do not use AMA if the disease is not infectious, untreatable, or self-limiting. Information regarding endemic infections and sensitivity pattern should be considered before selection of an AMA. Avoid overuse of newer AMA when an already available drug is equally effective. If AMA is needed, treatment should start from narrow-spectrum AMA first. prefer rapidly acting and bactericidal drugs, particularly where host defense is impaired. In combination of AMAs against resistant organisms, the individual agents should be used in full doses. Broad-spectrum antibiotics should be used only when a narrow-spectrum drug is not effective against an organism or unsuitable for the animal. Indiscriminate use of AMA should be stopped. AMA should not be used at subtherapeutic dose or unnecessarily for an extended period. Combination of AMAs. In general, AMAs should not be combined indiscriminately or without justification, but sometimes they are used in combination with specific objectives as below. To achieve additive or synergistic effects, the rule regarding combinations are bacteriostatic plus bacteriostatic is equal to additive or sometimes synergistic. Bactericidal plus bactericidal is equal to additive. Bactericidal plus bacteriostatic is equal to generally antagonistic. Synergistic combinations are used in full doses of individual drugs for achieving the goal. Next is to broaden the spectrum of antibacterial activity, to curb the development of resistance, and to decrease the intensity of toxic effects. Disadvantages of combination of AMAs. Increased chance of development of variety toxicity. Improper combination results in increase in intensity of toxicity of a drug by another. Promotion of development of resistance or increase in nephrotoxicity. Gentamicin plus cephaloridine. Chances of superinfections are increased. Generate a casual rather than a rational view in diagnosis of infectious diseases or selection of AMA. Increase in cost or therapy. Chemoprophylaxis. It is the use of AMA to prevent the setting of an infection in the body or to combat a contacted infection before its final clinical manifestation. It reduces the number of the viable microbe below the critical level, thus preventing infection. The chemoprophylaxis may be done against specific organisms. For prevention of infections in some high-risk situation, such as urinary tract catheterization, may be satisfactory, but it is highly unsatisfactory and condemnable, even hazardous, if it is done for prevention of infection in general. Misuse of AMAs. The misuse of antimicrobial agents is a significant public health concern with far-reaching consequences. Here are some key aspects of antimicrobial misuse: treatment of untreatable disease, improper dosage, superinfection, inhibition of starter bacteria, antibiotics as growth promoters, and application of antibiotics in surgical wounds without proper drainage. Next are the antibacterial agents. The antibacterial agents to be discussed are the sulfonamides, nitrofurans, nitroimidazoles, sulfones, quinolones and fluoroquinolones, the beta-lactam antibiotics, which are the penicillin, cephalosporins, carbapenems, monobactams, and the general considerations of protein synthesis inhibitors, which are the aminoglycosides, tetracyclines, chloramphenicol, macrolides, lincosamides, and peptide antibiotics. Sulfonamides. Sulfonamides were effective AMA to be used systemically in man against pyogenic bacterial infections. They are widely used antimicrobial agent in veterinary medicine because of their relative efficacy in some common bacterial diseases in animals and low cost. Classification of sulfonamides based on clinical uses. Sulfonamides used for systemic infections are the short-acting and long-acting. The short-acting are highly absorbed and rapidly excreted. These are sulfathiazole, sulfamethazine, sulfamerazine, sulfadiazine, and sulfapyridine. The long-acting are highly absorbed but slowly eliminated because of high protein binding or lipid solubility. These are the sulfamethoxypyridazine, sulfaethoxypyridazine, sulfamethoxine, and sulfachloropyridazine. Sulfonamides used to treat UTIs. These are sulfisoxazole, sulfafurazole, and sulfasomidine. These are highly water-soluble, rapidly absorbed and excreted through kidney, mostly unchanged, undergo least acetylation or acetylated crystals, are highly soluble even in acidic urine, with less potency to cause crystalluria, and attain high concentration in urinary tract. Gut-acting sulfonamides. These are poorly soluble and not absorbed in GIT. Thallyl sulfathiazole and succinyl sulfathiazole are prodrugs as such and hydrolyzed in the GIT by intestinal microflora to phthalic and succinic acid. The active sulfathiazole, sulfaguanidine, and sulfasalazine are also hydrolyzed in large intestine to sulfapyridine and aminosalicylic acid and is used in ulcerative colitis in dogs. Sulfonamides used topically to treat eye infections is a sulfacetamide sodium or locula as 30% solution or 10% ointment. They are highly soluble and yield non-irritating neutral solution. To treat burns and wounds, the silver sulfadiazine and mafenide are used. Potentiated sulfonamides are a type of antibiotic medication that combines two drugs, a sulfonamide and a pyrimidine potentiator. Pyrimidine potentiators work by blocking a different step in the folic acid pathway than sulfonamides. This combination creates a synergistic effect. Sulfadiazine and sulfadoxine with trimethoprim in the ratio of 5:1. Sulfonamides' mechanism of action. Folic acid is essential for the synthesis of nucleic acids. Bacteria synthesize their own folic acid from PABA with the help of the enzyme folic acid synthetase. Sulfonamides are structurally similar to PABA and competitively inhibit the enzyme folic acid synthetase. This results in folic acid deficiency and thereby inhibition of bacterial growth as well as injury to the bacterial cell. This is an illustration of how the sulfonamides inhibit dihydropteroate synthase and trimethoprim inhibits dihydrofolate reductase, therefore inhibiting the folic acid synthesis. Antimicrobial activity of sulfonamides. Broad spectrum, bacteriostatic but at higher concentration in urine, bactericidal. Active against bacteria chlamydia, toxoplasma, and coccidia. Drug resistance. Chromosomal mutation develops slowly and gradually. Plasmid-mediated resistance, which develops rapidly, which limits its usage in Staphylococcus, Streptococcus, E. coli, and Shigella. Sulfonamides administration and pharmacokinetics. They are administered orally, IV, IM, SC, IP, intrauterine, or topically. Parent sulfonamides use oral or topical routes. Monosodium salts use IV route only, since less water solubility and cause severe irritation by other routes. Disodium salts, IV, IM, SC, since they are highly water soluble. Therapeutic effective blood levels are 8 to 15 mg per 100 ml in man and 5 mg per 100 ml in animals. Absorption. They are rapidly absorbed from GIT except gut-acting sulfas. Available as bolus, tablets, feed mix, dispersible powder. IV. Alkaline, so slowly administered to prevent shock and perivascular reaction. IM and SC preparations should be suitably buffered. Distribution. Absorption. Most sulfonamides are well absorbed from the gastrointestinal tract after oral administration. Some may also be applied topically to wounds or burns. Plasma protein binding. Sulfonamides bind to plasma proteins, particularly albumin. This binding can affect the amount of drug available to fight infection. Distribution throughout the body. Once absorbed, sulfonamides are distributed throughout the body fluids and tissues. They can reach therapeutic concentrations in various organs, including the lungs, kidney, and cerebrospinal fluid. Metabolism. In liver, the primary site of metabolism for sulfonamides is the liver. Minor pathways. Some sulfonamides may undergo other modifications like hydroxylation. Metabolism. Main pathways. First is acetylation. This is the most common modification. The N4 position of the sulfonamide molecule gets attached to an acetyl group by the enzyme N-acetyltransferase. The percentage of a dose that undergoes acetylation varies depending on the specific sulfonamide. Glucuronide conjugation. This involves attaching a glucuronide molecule to the sulfonamide. making it more water-soluble for excretion. Next is excretion. Kidneys. The primary route of excretion for sulfonamides and their metabolites is through the kidneys. Factors affecting excretion. The urine pH. More alkaline urine can decrease the excretion of the unchanged drug and favor the excretion of acetylated forms. Acetylation. The extent of acetylation can influence excretion. Highly acetylated forms may be excreted faster than the parent drug. Sulfonamides toxicity and adverse effects. Acetylated derivatives of sulfa deposited in renal tubules, pelvis, and ureter cause renal colic, hematuria, obstruction of renal tubule, and increased BUN level. Renal toxicity. Decreased water consumption and acidic urine precipitate crystalluria, hematuria, and obstruction of renal tubules. Their drugs crystallize in acidic urine. Ensure adequate water intake and administration of sodium bicarbonate. Incidence is less with sulfadoxazole. Acute toxic effect. Rare but occur when rapid IV and excessive dose. This can lead to muscle weakness, ataxia, blindness, and collapse. Chronic toxic effect. Hematological alterations. Agranulocytosis, hemolytic anemia, reduction in cell count and hemoglobin levels, vesical hemorrhages, hepatic degeneration, cyanosis, jaundice, peripheral neuritis, myelin degeneration in dog and cats, drop in egg production, hepatic and renal insufficiency, anemia, agranulocytosis, and hypoprothrombemia in poultry. Here are the clinical uses of sulfonamides. In poultry, they are used for prevention of treatment of coccidiosis, infectious coryza poliarum disease, and fall typhoid. Dapsone, also called as diaminophenyl sulfone, is used for treatment of leprosy in humans. Here is a table for the dosage of sulfonamides. The first column indicates the type of drug, the second column is for the species, and the third column is the dosage, route, and frequency. Potentiated sulfonamides. These constitute the sulfonamides in combination with trimethoprim, which potentiates the antibacterial action of sulfonamides. Trimethoprim. This is a diaminopyrimidine derivative. Antibacterial spectrum is similar to sulfonamides. In addition, also effective against some sulfonamide-resistant organisms like S. typhi, E. coli, Klebsiella, and Haemophilus. They are bacteriostatic drugs and selectively acts by inhibiting bacterial dihydrofolate reductase enzyme. Trimethoprim. Its combination with sulfonamides results in potentiation of antibacterial action by sequential blockade at two steps in bacterial folate metabolism and nucleic acid synthesis. Trimethoprim resembles pteridine moiety of folate, selectively inhibits BHFRase, and produces bacteriostatic effect. Individually, both sulfonamide and trimethoprim are bacteriostatic, but their combination is bactericidal. Here are the common combinations of trimethoprim and sulfonamide: trimethoprim and sulfamethoxazole, trimethoprim and sulfadoxine, trimethoprim and sulfadiazine. These are used in UTI enteric infection, salmonella, and brucellosis. Also in salmonellosis, diarrhea, and pneumonia in cattle, and E. coli infections in poultry. The side effects are swelling at injection site, folate deficiency, transient arthritis in Doberman, keratoconjunctivitis, idiosyncratic thrombocytopenia, salivation in cats in uncoated oral tab, and generally, 3 days of withdrawal period is needed. The next antimicrobial agent is the nitrofurans. These are a group of synthetic antibacterial compounds which contain a furan ring to which a 5-nitro group is attached. The 5-nitro group is essential for the antibacterial action. Broad spectrum and effective against both gram-positive and gram-negative bacteria, and also against Salmonella, Coccidia, Giardia, and Amoebae. These are bacteriostatic in action but may be bactericidal at higher concentrations. However, when compared with other antimicrobial chemotherapeutic agents, their potency is of not particular note. Nitrofurans' mechanism of action. The nitrofurans appear to inhibit a number of microbial enzyme systems, including those involved in carbohydrate metabolism, and they also block the initiation of translation. However, their basic mechanism of action has not yet been clarified. It is reduced by bacterial flavoproteins to reactive intermediates that inhibit bacterial ribosomes and other macromolecules. Protein synthesis, aerobic energy metabolism, DNA and RNA synthesis, and cell wall synthesis are inhibited. Antibacterial activity reduced in presence of blood, pus, and milk. Mammalian cells take long time to convert it to metabolite, hence toxicity is not significant. Here is the mechanism of action of nitrofurans inhibiting a number of microbial enzyme systems. Nitrofurans are used for gram-positive, gram-negative bacteria, some protozoa, and fungi. They are moderate anaerobes, and Pseudomonas are resistant. They have activity more in pH less than 5.5 and well absorbed after oral administration. Resistant mutants are rare and clinical resistance emerges slowly. Among themselves, nitrofurans show complete cross-resistance, but there is no cross-resistance with any other antibacterial agents. Nitrofurans interact with nalidixic acid, and their interaction is antagonistic. Pharmacokinetics. Because of very slight water solubility, the nitrofurans are used either PO or topically. They are either not absorbed at all from the GI tract or are so rapidly eliminated that they reach inhibitory concentrations only in the urine. No nitrofurans is effective systemically. Toxicity. Toxic signs seen with excessive doses of nitrofuran derivatives include CNS involvement, GI disturbances, poor weight gain, and depression of spermatogenesis. Various hypersensitivity reactions can also be seen. Some nitrofurans are carcinogenic and their future use is in doubt. In clinical application, not useful systemically, slightly soluble in water, used orally and topically, especially in uterine infections. Other members of nitrofurans. Nitrofurazone, mainly in treatment of bovine mastitis, bovine metritis, and skin burn and wound infections. They are also used as feed additive at 0.05% to control intestinal bacterial and coccidial infections. Nitrofurantoin, mainly used as urinary antiseptic for the prevention and treatment of UTI, particularly in small animals, caused by susceptible bacteria such as Escherichia coli, Staphylococcus aureus, Streptococcus pyogenes, and Aerobacter aerogenes. Furazolidone, broad-range antimicrobial spectrum, effective against both G-positive and G-negative bacteria, Eimeria, and Histomonas species. Mainly used orally to bovine mastitis at 500 mg per quarter intramammarily. Strangles in horse, IV for 5 days. In addition, salmonellosis in chickens and at 0.04% in drinking water. Furaltadone. It is easily absorbed from GIT and has medium antibacterial spectrum. Used to treat bovine mastitis, strangles in horse, and salmonellosis in chickens. Nitroimidazoles. 5-nitroimidazole is an organic compound with the formula O2 and C3H 2N2H. The nitro group that position 5 on the imidazole ring is the most common positional isomer. The term nitroimidazole also refers to a class of antibiotics that share similar chemical structures. Nitroimidazole mechanism of action. After entry into the cell, it undergoes reduction under anaerobic conditions to produce unstable intermediates, which is responsible for antibacterial activity. It causes excessive breakage of DNA strand and inhibits DNA repair enzyme, DNAase. It is bactericidal. Reduction system is low in aerobes. Resistance is rare. It involves reduced intracellular drug activation. Cross-resistance between nitroimidazole is complete and some with nitrofurans. Here is an illustration of the mechanism of action of nitroimidazoles. Pharmacokinetics. It is well absorbed in monogastric and horses from GIT, highly lipophilic and excellent tissue penetration, even into blood-brain barrier. Oxidized and conjugated in the liver and 2/3 excreted unchanged in urine. Drug interaction. No interference with penicillin G, amoxicillin plus cloxacillin, cefoxitin, clindamycin, and erythromycin. Toxicity. At high dose, it causes neurotoxicity and reversible bone marrow suppression. It is carcinogenic and not used in food producing in animals in US and not approved by FDA for use in cattle. Teratogenic, not used in first trimester of pregnancy. In dog, it causes nausea, retching, and uneasiness. Clinical application. Nitroimidazole antibiotics have been used to combat anaerobic bacterial and parasitic infections such as amoebiasis, trichomoniasis, giardiasis, anaerobic bacterial infection, abdominal abscess, peritonitis, empyema, genital tract infection, meningitis, and necrotic tissue. Urethral douche in trichomoniasis in cattle, mixed infection in pyometra, swine dysentery, anaerobic pleuropneumonia, mixed infection of gastrointestinal tract in horses, acute gingivitis, periodontal disease, giardiasis, anal sac infection, and Clostridium difficile enteritis in dogs and cats. Next antimicrobial agent is the sulfones. Dapsone, also known as diaminodiphenyl sulfone or DDS, is an antibiotic commonly used in combination with rifampicin and clofazimine for the treatment of leprosy. It is a second-line medication for the treatment and prevention of pneumocystis, pneumonia, and for the prevention of toxoplasmosis in those who have poor immune function. Dapsone is available both topically and by mouth. Chemically related to sulfonamides and effective against Mycobacterium leprae. Mechanism of action. Like sulfonamides, it inhibits folate synthesis in sensitive bacteria through PABA antagonism. Uses. Dapsone is the drug of choice for treatment of leprosy in man, not commonly used in other bacterial diseases due to its potent toxicity. The other anti-leprosy drugs are rifampicin and ethionamide, clofazimine, and oil of Cholmugra hydnocarpus. Next, antimicrobial agent are the quinolones and fluoroquinolones. Quinolones are a group of synthetic antimicrobial agents. Nalidixic acid is the older agent in the group. Oxalic acid and siloxacin are other quinolones. They are synthetic antimicrobials having quinolone structure. The clinically important compounds under this group are divided into two classes. The first generation, which are the original quinolones, are nalidixic acid, oxalic acid, siloxacin, and resoxacin. They are primarily active against gram-negative bacteria, especially coliforms. Limited effectiveness against Pseudomonas species, mainly used for treating urinary and gastrointestinal tract infections, and usage restricted due to CNS toxicity, low potency, moderate blood and tissue levels, narrow spectrum, and high bacterial resistance. The second generation, or the fluoroquinolones, are ciprofloxacin and rofloxacin, norfloxacin, difloxacin, ofloxacin, pefloxacin, danofloxacin, marbofloxacin, and flumequin, enhanced antibacterial potency compared to the first generation quinolones, expanded spectrum of activity against a wider range of bacteria, better tissue penetrability for improved efficacy, reduced toxicity compared to first generation quinolones, slower development of bacterial resistance due to chemical modifications. Here is a table representing the quinolones and fluoroquinolones. The first column represents the first generation original quinolones, and the second column is the second generation or the fluoroquinolones. Mechanism of action. Fluoroquinolones inhibit bacterial enzymes DNA gyrase and topoisomerase 4, essential for DNA replication and transcription. DNA gyrase corrects excessive positive supercoiling of DNA during replication by introducing negative supercoils. Inhibiting DNA gyrase with fluoroquinolones halts DNA replication. Topoisomerase 4 is necessary for separating daughter cells after replication. Fluoroquinolones also inhibit this enzyme, blocking cell separation. An illustration on the right represents the mechanism of action of fluoroquinolones. This inhibition of DNA gyrase and topoisomerase 4 primarily targets gram-positive bacteria and gram-negative bacteria, respectively. Bactericidal action occurs as damaged DNA signals the production of exonucleases, leading to DNA digestion. Bactericidal action is rapid and concentration dependent. Mammalian cells possess topoisomerase 2, similar to bacterial DNA gyrase, but with low affinity for fluoroquinolones, reducing toxicity to host cells. Antimicrobial action. Fluoroquinolones exhibit high activity against both gram-negative aerobes and gram-positive aerobes. Among aerobic gram-negative bacilli, Enterobacteriaceae and Neisseria are particularly susceptible to fluoroquinolones, with minimal inhibitory concentration, typically below 0.1 micrograms per milliliters. Second-generation fluoroquinolones such as ciprofloxacin and ofloxacin also demonstrate activity against mycobacteria, mycoplasma, chlamydia, and rickettsia, while they are inactive against anaerobes. Pharmacokinetics. Quinolones and fluoroquinolones are administered orally, IM, SC, IV, and also topically. They are better absorbed after oral administration in monogastrites, preruminants, and absorption is poor in ruminants, but better in parenteral administration. Lipophilic, low degree of ionization, well distributed in tissues, bone cartilage, prostate, CSF, and can cross BBB and attain high concentration in CSF. High concentration in liver, bile, urinary tract, partially metabolized in liver and excreted in urine and bile. Urinary drug concentration exceeds serum concentration, hence low dose is sufficient in UTI. Toxicity. Quinolones and fluoroquinolones are relatively safe drugs. In humans, quinolones are associated with a small risk of tendonitis and tendon rupture, nausea, upper gastrointestinal tract discomfort, headaches, and dizziness. Skin rashes and photosensitivity are less common. Neurotoxic. They are sometimes prone for CNS convulsions. In pregnancy, embryonic loss and maternal toxicity can happen. In dogs, cartilaginous erosion leading to permanent lameness in young animals. Hence, not recommended for puppies less than 8 months in small breeds and 18 months in large breeds. Horses, not recommended because of arthralgic effect. Clinical application. Fluoroquinolones or FQs are extensively utilized due to their broad spectrum of activity, efficacy through both oral and parenteral routes, high tissue penetrability, and good tolerability. They are preferred for blind therapy, but caution is advised against their use for minor infections or when gram-positive organisms are suspected as the primary pathogens. In severe infections, initiating treatment parenterally is recommended. FQs excel in treating deep-seated infections and those caused by intracellular pathogens. Common applications include gram-negative septicemias, respiratory tract infections, gastrointestinal tract infections, urinary tract infections, skin infections, and eye infections. Additionally, they are effective in treating meningoencephalitis, bacterial prostatitis, osteomyelitis, arthritis, and mastitis. Certain members of the fluoroquinolone class are also utilized in the treatment of typhoid and tuberculosis in humans.
Next is beta-lactam antibiotics. Beta-lactam antibiotics are a class of broad-spectrum antibiotics consisting of all antibiotic agents that contain a beta-lactam ring in their molecular structure. This includes penicillin derivatives, cephalosporins, monobactams, and carbapenems. Most beta-lactam antibiotics work by inhibiting cell wall biosynthesis in the bacterial organism and are the most widely used group of antibiotics. So what is the physiochemical properties of beta-lactam antibiotics? The physical and chemical properties, especially solubility of penicillins, are related to the structure of the acyl side chain and the cations used to form salts. Hydrolysis is the main cause of penicillin degradation and can take place in the syringe when penicillin is mixed with another drug. Some penicillins are rapidly hydrolyzed by gastric acid, making them unsuitable for oral administration. The aqueous solutions of the alkaline sodium salts of sulfonamides inactivate penicillin. Also, penicillin is incompatible with heavy metal ions, oxidizing agents, and strong concentrations of alcohol. Next is the classification of penicillins. Penicillins can be broadly classified into two main categories: the natural penicillin and the semi-synthetic penicillins. Each class of penicillin has its unique properties, modes of administration, and spectrum of action, which we will explore in detail. First, let's talk about the soluble sodium or potassium salts of benzyl penicillin or the penicillin G. They are not orally active, as it can be destroyed by gastric acid and also be degraded by penicillinase enzyme. They are administered via intramuscular, intravenous, and subcutaneous. Onset of action is within half an hour and duration of action is only 3 hours. Next type of natural penicillin is the sparingly soluble organic salts of penicillin G or repository penicillins. So in procaine penicillin G, this formulation is intended for intramuscular injection only, as intravenous administration can lead to serious complication. It has a slower onset of action, typically between 6 to 8 hours, and remain effective for 12 to 24 hours. Similar to penicillin G, it is destroyed by gastric acid and penicillinase enzyme. A notable drawback of procaine penicillin G is the high incidence of hypersensitivity reactions among patients. In benzathine penicillin G, it is exclusively administered via intramuscular injection and is distinguished by its low onset and prolonged duration of action, lasting up to 1 week. Next classification of penicillin is the semi-synthetic penicillin that are chemically modified derivatives of natural penicillins. In acid-resistant penicillins, it includes phenoxymethylpenicillin or the penicillin V, phenoxyethylpenicillin or the penicillin. In the penicillinase-resistant penicillin, in acid-labile penicillin, it includes methicillin and nefacillin. In acid-resistant penicillin, it includes flucloxacillin, oxacillin, and dicloxacillin. The last semi-synthetic penicillin is the extended-spectrum penicillins. In aminopenicillin, ampicillin, vacampicillin, talampicillin, pivampicillin, and amoxicillin fall into this category. These antibiotics have been modified to enhance their effectiveness against a broader range of bacteria, including both gram-positive and gram-negative organisms. In carboxypenicillin, or the anti-pseudomonal penicillin, carbancillin and ticarcillin are active against Pseudomonas aeruginosa and Proteus species, but is ineffective against Klebsiella and gram-positive cocci. Ureadepenicillin are active against Pseudomonas and Klebsiella, and it includes meslocillin and piperacillin. The last is the amidinopenicillins. Mesillinum and pivmesillinum exhibit high activity against gram-negative bacilli such as E. coli, Salmonella, Klebsiella, and Enterobacter, but are not effective against Pseudomonas and gram-positive cocci. The next is the mechanism of action of penicillin. The cell wall of gram-positive bacteria is made of peptidoglycan, which consists of alternating amino sugars of N-acetylglucosamine and the N-acetylmuramic acid, linked by peptide chains through a process called transpeptidation. This structure provides the cell wall with its rigidity and stability. Beta-lactam antibiotic, which includes drug like penicillin, work by disrupting the synthesis of the bacterial cell wall, thus compromising the integrity of the bacteria. They achieve this by binding to enzymes and proteins, notably the penicillin-binding proteins, which are crucial for the final steps of the cell wall synthesis. The beta-lactam ring mimics the D-alanine structure in the peptidoglycan, inhibiting the cross-linking of peptidoglycan chains and leading to the creation of defective cell walls that cannot withstand osmotic pressure, resulting to bacterial lysis and death. Variety of penicillin-binding proteins across bacterial species and their differing affinities for beta-lactam antibiotics explain the varied effectiveness of these drugs against different bacteria. Gram-negative bacteria, which can have multiple penicillin-binding proteins, show resistance to the bactericidal effects of beta-lactam antibiotics, which is not observed in gram-positive cocci due to differences in their cell wall structures and the penicillin-binding proteins. Mechanism underlies the specific action of beta-lactam antibiotics and their spectrum of activity against different types of bacteria. The next slide is the microbial resistance. Bacterial susceptibility to beta-lactam antibiotics, a crucial class of antibacterial agents, is influenced by three independent factors: the production of beta-lactamases, the permeability of the cell wall, and the sensitivity of penicillin-binding proteins. The major mechanism of drug resistance is the elaboration of beta-lactamases enzyme that inactivate the drugs by hydrolyzing the beta-lactam ring. Different bacteria produce beta-lactamases that differ in physical, chemical, and functional properties. Some beta-lactamases are specific for penicillinases, some are specific for cephalosprinases, while still others have affinity for both groups. There are two mechanisms of beta-lactamase production: the chromosomal-derived and the plasmid-derived. The chromosomally-derived beta-lactamases are species and genus specific and can be induced by the presence of any beta-lactam compound. The plasmid-derived beta-lactamases can be transferred between bacteria, increasing the number of bacteria resistant to the antibiotic. So, gram-positive bacteria typically produce chromosomally-derived beta-lactamases, while gram-negative bacteria can produce both chromosomally-derived, especially the cephalosprinases, and plasmid-mediated beta-lactamases. The latter are often broader spectrum. Furthermore, gram-negative bacteria secretes small amounts of beta-lactamases into their periplasmic space, allowing for optimal location of the enzyme to degrade the beta-lactam upon entry into the organism. Newer agents have increasing resistance to beta-lactamases. For example, the cefamycin are apparently stable to chromosomally mediated beta-lactamases, which may give them their excellent activity against anaerobic gram-negative rods. Next is the microbial susceptibility of natural penicillin, aminopenicillin, penicillinase-resistant penicillin, and the extended-spectrum penicillins. Natural penicillin, they exhibit activity against various bacteria, including many streptococci and non-penicillinase-producing staphylococci species. It is also effective against certain gram-positive and gram-negative bacilli, such as Corynebacterium, Listeria monocytogenes, Pasteurella multicida, and Haemophilus influenza. It is also active against numerous gram-positive and gram-negative anaerobic bacteria, including Fusobacterium, certain strains of Clostridium, and Streptococcus. It also demonstrates effectiveness against most spirochetes like Leptospira and Borrelia burgdorferi. However, it is inactive against Pseudomonas, most Enterobacteriaceae, and penicillinase-producing Staphylococcus species. In aminopenicillins, they are generally active against the microbes that are susceptible to natural penicillins. They are also active against some Enterobacteriaceae, including strains of E. coli, Proteus mirabilis, and Salmonella. However, they are also inactive against Pseudomonas, Bacteroides fragilis, and penicillinase-producing Staphylococcus species. In the penicillinase-resistant penicillin, they are active against many penicillinase-producing Staphylococcus species, which are resistant to the natural penicillin and the aminopenicillins. They have some activity against other gram-positive and gram-negative bacteria and spirochetes, and they are less effective than the other penicillins. Lastly, the extended-spectrum penicillin have the most activity against gram-negative aerobic and anaerobic bacteria of all of the penicillin groups. They are active against many strains of Enterobacteriaceae and some strains of Pseudomonas. Carbancillin and tecarcillin are active against some strains of E. coli, Morganella morgana, Proteus species, and Salmonella. Meslocillin and piperacillin are active against some strains of Enterobacter, Citrobacter, Klebsiella, and Sriracha. They also have some activity against gram-positive aerobic and anaerobic bacteria, but are generally less effective against these organisms than are the natural penicillin and aminopenicillin. They are generally more active against Bacteroides fragilis than other available penicillin. Next is the pharmacokinetics of beta-lactam antibiotics. Most penicillins are rapidly absorbed when injected in aqueous suspension by the intramuscular or the subcutaneous route. Maximum blood concentration result in 15 to 30 minutes. Intramuscular injection is the most common route of administration. It is necessary to orally administer 5 times the amount of penicillin gene necessary for intramuscular injections to produce comparable blood concentrations because of inactivation of the gastric acid and enteric bacteria. An absorption of penicillin occurs during the first few hours after intramammary infusion. Blood concentrations are consistently higher when penicillin is infused in infected quarters than when infused into normal quarters. Serum plays a significant role in transfer of penicillin from treated to untreated quarters. There is a systemic absorption of sodium benzylpenicillin and procaine benzylpenicillin administered intrauterine to horses and cattle, respectively. The sodium or potassium penicillin, when suspended in an inert oil, prolongs the absorption of penicillin from the infection site for about 18 hours. Similarly, incorporating procaine penicillin in oil extends absorption to 24 hours or more. However, the addition of 2% aluminum monoesterate to oil suspension forms a gel with high water repellency, significantly slowing the absorption of procaine penicillin. While oil vehicles help maintain therapeutic blood levels, their limited use is due to undesirable physical properties. The horses may exhibit unfavorable acute and chronic tissue reactions to parenterally administered antibiotic in oil vehicles. To address this, buffered aqueous suspension of procaine penicillin G are available for intramuscular injection. Procaine in these suspensions prolongs penicillin absorption but may pose issue in drug testing programs for racing horses. To counteract this, a small amount of sodium or potassium penicillin G may be added to quickly establish therapeutic concentrations post-injections. Benzathine penicillin G is a repository salt of penicillin. The absorption of this compound may be prolonged for 7 or more days. Diffusion of penicillin into the tissues and fluids occurs as long as the unbound plasma concentration exceeds that of the tissues and fluids. High concentrations of penicillin are generally reached in kidneys, liver, and lungs. Penicillins do not penetrate the CNS to any great extent. Penicillin will diffuse across the placenta into the fetal circulation. Tissue residues of penicillin in slaughtered animals are considered a public health hazard because of potential hypersensitivity reactions in people. Penicillin G, penicillin V, nafacillin, ticarcillin, and the aminopenicillins are metabolized to some extent by hydrolysis of the beta-lactam ring. The metabolites are microbiologically inactive. Penicillins and their metabolites are excreted in the urine by tubular secretion. Most of the drug is excreted in the urine within 1 hour of intramuscular injection of sodium or potassium penicillin in an aqueous solution. Probenecid competitively inhibits renal tubular secretion of penicillins. Penicillin is also eliminated in milk. Now, let's talk about penicillins in details. First is the natural penicillin, which includes penicillin G or the benzylpenicillin. Penicillin G has narrow spectrum and is effective against gram-positive cocci, bacilli, and a few gram-negative coli. Thus, streptococci, pneumococci, gonococci, meningococci, bacillus anthracis, Corynebacterium diphtheriae, Clostridia, Listeria, and Spirochetes are highly sensitive. They are also active against some anaerobes. Benzylpenicillin is destroyed by gastric juice or the acid labile, has very low bioavailability, hence given parenterally. Food also interferes with its absorption, hence it should be given 2 hours before or after food. Procaine penicillin G should not be administered via IV because procaine can adversely affect the cardiac conduction system. Penicillin is usually not administered orally to herbivores because it suppresses bacterial metabolism in the digestive tract. The exception are those herbivores that are very young or animals that require suppression of bacterial fermentation to prevent bloating. Penicillin is administered via both intramural and systemic routes to treat bovine mastitis. Milk contaminated with antibiotics may cause public health problems as well as inhibit the cheese-making process. Penicillin in milk and milk products may sensitize susceptible humans, with subsequent penicillin therapy more likely to produce an allergic reaction or hypersensitivity. Recommended withdrawal times must be adhered to. The type of vehicle used in intramammary infusion preparation is a factor that also determines time required for elimination of antibiotics via the milk. In general, penicillin in fat-soluble ointments or mineral oils vehicles persists longer in the bovine udder than penicillin administered in an aqueous vehicle. In contrast, aqueous vehicle favored rapid release of antibiotics to attain maximum therapeutic concentrations. So, what are the adverse effects of penicillins? Penicillins are highly safe drugs with a high therapeutic index. The most adverse reactions are not serious in therapeutic doses except hypersensitivity reactions. Hypersensitivity is the most common cause of allergy. Degradation products of penicillin like penicilloic acid is antigenic. Allergic reactions range from skin rashes, urticaria, pruritus, fever, bronchospasm, serum sickness, and rarely exfoliative dermatitis and anaphylaxis. Though all forms of penicillin can cause allergy, anaphylaxis is more common following parenteral than oral preparation. A syringe loaded with adrenaline to treat anaphylaxis should be kept ready. Local pain at the site of intramuscular injection, thrombophlebitis on IV injection, particularly large doses due to irritation. In CNS, large doses of penicillin G greater than 20 megaunits injected IV may produce confusion, muscle twitching, convulsions, and coma, particularly in presence of renal disorder. Superinfections are rare because of the narrow spectrum of penicillins. In repository penicillins, oral penicillin can be used only in minor infections, and benzylpenicillin is short-acting. Hence, repository penicillin like procaine penicillin and benzathine penicillin are formulated so that they are slowly absorbed with the prolonged blood levels and are longer-acting. Given deep intramuscular, they are released penicillin slowly from the site. Procaine penicillin is given 12 to 24 hourly, while a single injection of benzathine penicillin is effective for 3 to 4 weeks. Next is the semisynthetic penicillin. First is the acid-resistant penicillins. Penicillin V or the phenoxymethylpenicillin is an acid stable and can be given orally. It is used only in mild infections as it has a low bioavailability, short action, 6 hourly dosing, and a narrow spectrum of activity. It may be given in streptococcal pharyngitis, sinusitis, and strange mouth. Second is the penicillase-resistant penicillin. Methicillin sodium is a water-soluble penicillinase-resistant penicillin that produces therapeutic concentrations in the CNS. Methicillin is primarily used as an anti-staphylococcal drug. However, methicillin is a powerful inducer of penicillinase, and staphylococci may develop resistance by non-penicillinase mechanism. Methicillin is also given by the IV or IM route and is usually well tolerated. Occasionally, some pain may be observed following IM injection. Oxacillin, cloxacillin, dicloxacillin, and nafacillin resist acid hydrolysis and can be administered orally. The last is the extended spectrum penicillins. Carbenicillin and similar drugs offer a notable advantage in their effectiveness against resistant gram-negative bacteria like Pseudomonas and Proteus. While carbenicillin itself is acid-labile and requires parenteral administration, carbenicillin indanyl, an ester, is an acid stable and suitable for oral use. with rapid absorption and peak plasma concentrations within an hour of ingestion. Carbonicillin is primarily eliminated via renal tubules, with a significant portion, which is 80%, excreted in urine within 9 hours. However, its low peak serum concentrations following oral administration may limit its efficacy against certain infections, unless localized to the lower urinary tract. Ticarcillin and meslocillin must be administered via IV or IM as they are not absorbed orally. Next is the toxicity of beta-lactam antibiotics. Penicillins are very safe drugs, with relative few adverse effects reported. Acute allergic reactions are the most common untoward effect in people. Acute anaphylaxis, collapse, hypersalivation, shaking, vomiting, urticaria, fever, eosinophilia, neutropenia, agranulocytosis, thrombocytopenia, leukopenia, anemia, and lymphadenopathy can occur in sensitized animals. Coombs-positive hemolytic anemia has been reported in horses following penicillin administration. The IV administration of hypertonic solutions of sodium benzyl penicillin has resulted in ataxia and convulsions in cats and dogs. Procaine can also cause anaphylaxis and CNS disorders. Guinea pigs, chinchillas, birds, snakes, and turtles are sensitive to procaine penicillin. So, beta-lactamases are enzymes produced by penicillin-resistant bacteria, which break the antibiotic into inactive penicilloic acid. They are named as beta-lactamases as they act by splitting the beta-lactam rings present in beta-lactam antibiotic, penicillin and cephalosporin. These enzymes are of two types, the penicillinases and cephalosporinases. What is beta-lactamase inhibitor? Beta-lactamase inhibitor potentiate or reestablish the antibacterial potency of penicillinase-sensitive penicillins against beta-lactamase-producing organisms by inhibition of the enzyme. These inhibitors are structurally similar to penicillin and act as a substitute for penicillinase or beta-lactamase causing inhibition of enzyme. These are the clavulanic acid, sulbactam, and the tazobactam. Clavulanic acid, obtained from Streptomyces clavuligerus, has no antibacterial activity of its own. It is generally combined with amoxicillin or ticarcillin. Next is sulbactam. It is a semisynthetic beta-lactamase inhibitor related chemically and in activity to clavulanic acid. It is combined with ampicillin and preferably for oral and parenteral administration. Last is the tazobactam. It is similar to sulbactam and combined with piperacillin. Next is the potentiated penicillins. These are penicillins that are combined with beta-lactamase inhibitors. The combinations are clavulanic acid plus amoxicillin, a ratio of 2:1, and clavulanic acid plus ticarcillin with a ratio of 15:1.
Let's talk about now the use of clavulanic acid plus amoxicillin combination. Clavulanic acid is a beta-lactamase inhibitor that is frequently combined with amoxicillin to fight antibiotic resistance by preventing their degradation by the beta-lactamase enzymes, broadening their spectrum of susceptible bacterial infections. Clavulanic acid is derived from the organism Streptomyces clavuligerus. When it is combined with amoxicillin, it is frequently known as augmentin. This combination shows excellent activity against gram-positive bacteria, including beta-lactamase-producing Streptococcus aureus, fastidious gram-negative bacteria, and strains resistant to amoxicillin, the Enterobacteriaceae, and most anaerobes. However, some organisms, including Citrobacter, Enterobacter, Pseudomonas, Sriracha, and MRSA, shows resistance. Resistance is a growing concern. The combination can induce beta-lactamase production in some bacteria, leading to resistance through various mechanisms, including hyperproduction of beta-lactamase and reduced antibiotic uptake. Next is the pharmacokinetics of this combination. After oral administration, this combination is well absorbed and is similar to amoxicillin. It is distributed throughout the body but has limited penetration into the milk and CSF unless there is an inflammation. Elimination half-life is about 75 minutes and is eliminated largely unchanged in urine, with some biliary excretion. Generally, this drug is well tolerated. Mild gastrointestinal upset can occur in dogs and cats. It is crucial not to use this in animals allergic to penicillin or cephalosporins and to avoid certain administration routes in specific animals. In veterinary medicine, this combination has shown great results in treating infections in various animals. In cattle, sheep, and goat, lower respiratory tract infection, anaerobic soft tissue infections, and neonatal diarrhea caused by E. coli and Salmonella are treated. In cattle, it is used to treat clinical mastitis administered via parenteral and intramammary. It is also used to treat pasteurellosis in sheep, neonatal diarrhea caused by E. coli in swine, and mixed infections, lower respiratory tract infection, and anal sacculitis, gingivitis, urinary tract infection, and peritonitis due to intestinal spillage are also treated in dogs and cats. Clavulanic acid is also combined with ticarcillin to fight antibiotic resistance. This combination has greater activity against Enterobacter and Pseudomonas aeruginosa and majority of ticarcillin-resistant organisms. It is available for via IV administration and needs frequent dosing at 8-hour interval. Next is sulbactam. It is a synthetic derivative of 6-amino-penicilloic acid and is poorly absorbed orally, but its product sultamicillin improves oral absorption. It lacks direct antibacterial activity but effectively binds irreversibly to beta-lactamases, enhancing the efficacy of beta-lactam antibiotics. Sulbactam has lower affinity for beta-lactamases compared to clavulanic acid. It is commonly combined with ampicillin due to similar pharmacokinetic properties and with cefoperazone for synergistic effect. The combination of sulbactam and ampicillin is well absorbed after intramuscular use. It is well distributed into extracellular space and enters the CSF through inflamed meninges with a half-life of 1 hour. The injection may be painful, otherwise it is well tolerated. It is also should not be used in hindgut digesters like horse, rabbit, and etc. It is used in bovine respiratory disease and extra-label use for salmonellosis. Next is tazobactam. Tazobactam exhibits broader activity than both clavulanic acid and sulbactam. It demonstrates resistance to hydrolysis by certain beta-lactamases. When combined with piperacillin at a ratio of 8:1, it yields enhanced efficacy against Pseudomonas infections. Piperacillin and tazobactam combination possesses broad spectrum of activity against many Enterobacteriaceae and other gram-negative bacteria. It is also active against anaerobes and gram-positive organisms. It is used to treat polymicrobial infections and is effective like imipenem or clindamycin gentamicin. Along with aminoglycoside, it is used to treat fever in neutropenic patients. Next beta-lactam antibiotic is the cephalosporin. Cephalosporins are semisynthetic antibiotics with a beta-lactam ring, closely related to penicillins. They are derived from Cephalosporin C, which originates from mold species within Cephalosporium, particularly Cephalosporium acremonium. In the structure of cephalosporin, the nucleus consists of a beta-lactam ring fused to a dihydrotiazine ring and exhibits a broad spectrum bactericidal activity and are characterized as weak acids. In the case of structural activity relationship, cephalosporins possess distinct structural features that contribute to their efficacy and resistance against beta-lactamases. The beta-lactam ring in cephalosporin is fused to a 6-membered dihydrotiazine ring, rendering the cephalosporin nucleus inherently more resistant to beta-lactamases compared to the penicillin nucleus. Additionally, the 7-aminocephalosporanic acid molecule offers more site for modification, enabling the production of various semisynthetic drugs. Cephalosporins exhibit stability against beta-lactamases, good activity against target proteins, and the ability to effectively penetrate bacterial cell walls. Introduced for treating penicillinase-resistant staphylococci infections, cephalosporins remain a vital class of antibiotics with a diverse therapeutic applications. The mechanism of action of cephalosporins is similar to the penicillin. It binds to the penicillin-binding proteins and inhibits the action of transpeptidase. It is time-dependent and also needs frequent administration. It has no post-antibiotic effect and it is effective in rapidly growing organisms. Cephalosporins are classified in two generations based on antibacterial spectrum and beta-lactamase stability. Let's start with the first generation of cephalosporins. Based on the route of administration, cephalosporins can be classified into those primarily used orally and those administered via parenterally. In oral administration, you can use cephalexin, cephradine, and cefadroxil. In parenteral administration, you can use cephalotin, cefapyrin, cefazolin, cefaluridine, and cephalonium. In terms of spectrum of activity, the first generation cephalosporins display commendable activity against gram-positive cocci, including penicillinase-producing, methicillin-susceptible Staphylococcus aureus, and various Streptococcus species. It is important to note, however, that these agents are not the first line of treatment for such infections and exhibit no activity against methicillin-resistant Staphylococcus aureus or Enterococcus species. These antibiotics also cover a range of gram-negative organisms. They are particularly effective against Proteus mirabilis, some Escherichia coli, and Klebsiella pneumoniae. However, their efficacy does not extend to Bacteroides fragilis, Pseudomonas, Acinetobacter, Enterobacter, indole-positive Proteus, or the Sriracha. Next is the second generation. The second generation cephalosporins advance upon the first generation by extending their spectrum of activity, particularly against gram-negative bacteria. These antibiotics are available for both oral and parenteral administration. In oral administration, you can use cefaclor, cefuroxime, and cefaxetil. Parenteral administration, you can use ceftriaxone, cefotaxime, cefoperazone, ceftazidime, and cefzolodine. In case of spectrum of activity, the activity of second-generation cephalosporins against gram-positive bacteria is generally less than observed with the first-generation cephalosporins. The hallmark of the second-generation cephalosporins is their enhanced activity against wider array of gram-negative bacteria. This includes the coverage of Haemophilus influenzae, Enterobacter aerogenes, and some Neisseria plus the PEC. Next is the third-generation cephalosporins. It represents an evolution in the cephalosporin class, offering broad-spectrum activity with a significant emphasis on gram-negative bacterial coverage. In oral administration, you can use cefixime and cefdinir. In parenteral administration, you can use cefamandole, cefoxetin, cefuroxime, and cefchofor. In case of spectrum of activity, some members of this group, in particularly those available in an oral formulation and those with anti-pseudomonal activity, they have decreased activity against gram-positive organism. The activity against staphylococci and streptococci is less with the third-generation compounds than with the first and second-generation compounds. In gram-negative organisms, third-generation cephalosporins have a broad spectrum of activity and further increased activity against gram-negative organisms. They may be particularly useful in treating hospital-acquired infections, although increasing levels of extended-spectrum beta-lactamases are reducing the clinical utility of this class of antibiotics. They are also able to penetrate the central nervous system, making them useful against meningitis caused by pneumococci, meningococci, Haemophilus influenza, and susceptible E. coli, Klebsiella, and the penicillin-resistant Neisseria gonorrhea. Next is the fourth generation cephalosporins. In oral administration, you can use cefepime, cefclidine, and cefkinome, which is not approved for human use. In parenteral administration, you can use cefiprome. Based of spectrum of activity, they are extended spectrum agents with similar activity against gram-positive organisms as first generation. The fourth generation cephalosporins are zwitterions that can penetrate the outer membrane of gram-negative bacteria. They also have greater resistance of beta-lactamases than the third generation cephalosporins. Many can cross the blood-brain barrier and are effective in meningitis. They are also used against Pseudomonas aeruginosa. The last one is the fifth generation. In oral administration, you can use ceftaroline and ceftolozane. In parenteral administration, you can also use ceftobiprole. In case of the spectrum activity and the clinical use of these drugs, ceftobiprole has been described as a fifth-generation cephalosporin, though acceptance for this terminology is not universal. Ceftobiprole has powerful anti-pseudomonal characteristics and appears to be less susceptible to development of resistance. In ceftaroline, it also has been described as fifth-generation cephalosporin but does not have the anti-pseudomonal. In ceftolozane, it is a new option for treatment for complicated intra-abdominal infections and complicated urinary tract infections. Ceftolozane is combined with the beta-lactamase inhibitor tazobactam as a multi-drug-resistant bacterial infection will generally show resistance to all beta-lactam antibiotics unless this enzyme is inhibited. Next is the classification, antibacterial spectrum, and the pharmacokinetics. In the first generation, the antimicrobial activity is similar to aminopenicillins with the addition of moderate resistance to beta-lactamases of the Staphylococci aureus. It has high activity against gram-positive but are only with moderate to weaker activity against gram-negative organisms, relatively susceptible to cephalosporinase, and are effective against anaerobes. It is also used as an alternative to penicillin G in staphylococcal infection and for surgical prophylaxis. Based on the route of administration, the oral administration of this antibiotic is well absorbed in monogastrites and not affected by food except encefadrin. It is also well distributed, excreted unchanged in urine, and absorption is poor in horses and ruminants. In case of parenteral administration, it is well absorbed and poor penetration across a biological membrane. Notably, cephalotin and cefalferin undergo metabolism to form a less active diacetyl derivative, which can influence their clinical efficacy and duration of action. Like their orally administered counterparts, most parenterally administered cephalosporins are rapidly eliminated from the body through the urine. This rapid elimination contributes to a relatively short half-life for these drugs, typically less than 1 hour. Cephalosporins, like many antibiotics, undergo elimination primarily through renal process involving glomerular filtration and active tubular secretion. In second-generation cephalosporins, they are primarily administered parenterally with the exception of cefaclor, which is available for oral administration. Absorption of orally administered cefaclor can be affected by the presence of food, potentially altering its bioavailability. Second-generation cephalosporins demonstrate greater stability to beta-lactamase enzymes compared to earlier generations. This increased stability enhances their efficacy against bacteria that produce beta-lactamase, a common mechanism of antibiotic resistance. They also exhibit broader spectrum of activity, lower gram-positive activity, and higher gram-negative activity. Second-generation drugs are cefamandole, cefoxitin, cefuroxime, cefuroxime acetic, and ceftufor. They are reserved for life-threatening infections caused by gram-negative bacteria, especially Enterobacteriaceae, and meningitis by E. coli and Klebsiella. In terms of antimicrobial activity, the second generation are active against beta-hemolytic streptococci and beta-lactamase-producing staphylococci but not against methicillin-resistant staphylococci. Mycobacteria and most enterococci are all resistant. E. coli and Salmonella are susceptible. In third and fourth generation, they can be administered both parenteral and oral. They are stable to beta-lactamase of gram-negative bacteria, suitable for oral administration. They have reduced gram-positive activity to Streptococcus and not Staphylococcus. They have extended gram-positive activity, including Sriracha, Staphylococcus enteric organism, and Pseudomonas, and they can able to cross blood-brain barrier. Third-generation drugs are cefoperazone, ceftazidimine, ceftriaxone, and cefotaxime, which can be administered via IM or IV, used in meningitis and brain abscess. Last is cefixime, used orally. In fourth-generation drugs, it possesses an expanded spectrum of activity targeting both gram-positive and gram-negative bacteria concurrently. Cefepime stands out as a representative of this class. Now, let's talk about the pharmacokinetic characteristics of cephalosporins, which influence their absorption, distribution, metabolism, and excretion in the body. Cephalosporins exhibit variable bioavailability depending on the route of administration. While parenteral administration typically ensures good bioavailability, oral administration can be affected by the presence of food in the gastrointestinal tract. Certain cephalosporins, such as cefaclor and cefradin, demonstrate reduced bioavailability when taken orally with food. One crucial consideration in cephalosporin therapy is their ability to penetrate the blood-brain barrier. While most cephalosporins have poor blood-brain barrier penetrations, exceptions include cefotaxime, ceftriaxone, cefepime, cefuroxime, and ceftazidime. Cephalosporins also exhibit variable degrees of plasma protein binding. For instance, ceftriaxone demonstrates high protein binding, which is 80 to 95%, while cefadroxil binds to a lesser extent, about 20%. In terms of excretion, cephalosporins are primarily excreted unchanged in the urine, with renal clearance playing a significant role in their elimination from the body. The cefotaxime, cefalferin, and cefalotine are diacetyl derivative type of drug. Next is the resistance pattern in cephalosporin antibiotics. Resistance to cephalosporin antibiotics can occur through various mechanisms, broadly categorized into three types: the constitutive, acquired, and the chromosomal in resistance. The constitutive resistance refers to the inherent resistance present in bacterial strains, often due to the production of beta-lactamase enzymes located in the periplasmic space. These enzymes hydrolyze the beta-lactam ring of cephalosporin antibiotics, rendering them ineffective against the bacteria. In the acquired resistance, it involves the acquisition of resistance genes through horizontal gene transfer, often mediated by plasmids. These plasmids can easily spread among bacterial populations, facilitating the rapid dissemination of resistance, particularly in gram-negative organisms. In the chromosomal type of resistant, it arises from the mutation or alteration in chromosomal DNA, leading to the production of beta-lactamase enzyme encoded within the bacterial chromosome. Next, we're gonna talk about the mechanisms that bacteria employ to resist the effects of cephalosporin antibiotics. Resistance to cephalosporin antibiotics can occur through various mechanisms, each posing unique challenges in clinical practice. The three primary mechanisms of resistance include PBP modifications, reduced permeability and increased efflux, and enzymatic inactivation by beta-lactamases. In penicillin-binding protein modification, it is seen in some human pathogens, but is not recognized in bacterial pathogens of animals. Another common mechanism of resistance involves the reduction in bacterial cell permeability and increased efflux of cephalosporin antibiotics. Bacteria may produce furoporins, which are channels that beta-lactam antibiotics use to penetrate the bacterial cell wall. Additionally, the presence of periplasmic beta-lactamase enzyme can further contribute to reduce antibiotic penetration. Perhaps the most well-known mechanism of resistance is enzymatic inactivation by beta-lactamases. These enzymes hydrolyze the beta-lactam ring of cephalosporin antibiotics, rendering them inactive against bacterial pathogens. The extent of resistance often depends on factors such as the plasmid copy numbers or the induction of chromosomal enzymes. Cephalosporin antibiotics, while effective against many bacterial pathogens, encounter specific challenges that can impact the results. One significant challenge faced by cephalosporin antibiotics is their inability to penetrate the outer membrane of certain bacteria, particularly gram-negative organisms. Also, alteration in penicillin-binding proteins or target sites represent another mechanism of resistance that can impact the results of cephalosporin therapy. And lastly, certain cephalosporins such as ceftriaxone, cefoxitin, cefoperazone, and cefomandol are primarily excreted via the biliary system. Cephalosporin antibiotics are utilized in both human and veterinary medicine for the treatment of wide range of bacterial infections. Despite some limitations, these antibiotics offer valuable therapeutic options for clinicians. Cefazolin is commonly used for surgical prophylaxis to prevent post-operative infections in both humans and animals. The cephaloxin is effective in treating bacterial dermatitis in both humans and animals as well. Chufur is commonly used in veterinary medicine for the treatment of shipping fever in cattle and urinary tract infections in various animal species. Ceftriaxone and cefotaxime are preferred choices for the treatment of bacterial meningitis in both pediatric and adult patients. Lastly, the cefoperazone, cefsolodine, and ceftazidime effective against Pseudomonas aeruginosa infections, which are notorious for their resistance to multiple antibiotics. Lastly, although cephalosporins are generally well tolerated, they can occasionally cause adverse effects ranging from mild gastrointestinal symptoms to more severe reactions. Ceflarodine, a first-generation cephalosporin, is known to cause nephrotoxicity, which manifests as kidney damage. The intramuscular injections of cephalosporins can be painful, while repeated intravenous administration may lead to phlebitis and inflammation of the vein. Proper injection techniques and site rotation can help minimize these reactions. Also, gastrointestinal side effects such as nausea, vomiting, and diarrhea may occur occasionally with cephalosporin use. These symptoms are usually mild and resolve upon discontinuation of the antibiotic. Like other antibiotics, cephalosporins can disrupt the normal balance of microorganisms in the body, leading to superinfections. Clinicians should be vigilant for signs of secondary infections during treatment. Also, some cephalosporins, including cefamandole, cefoperazone, and mosolactam, may interfere with vitamin K metabolism, potentially leading to bleeding disorders. Monitoring of coagulation parameters is essential in patients receiving these antibiotics. Also, hypersensitivity reactions ranging from mild rashes to severe anaphylaxis can occur with cephalosporin antibiotics, especially in patients with a history of acute penicillin allergy. Cross-reactivity between penicillins and cephalosporins may occur and should be considered. And lastly, certain cephalosporins can block the second step in alcohol oxidation, leading to the accumulation of acetaldehyde. Patients should be advised to avoid alcohol consumption while taking these antibiotics to prevent adverse reactions. Next is the general considerations of protein synthesis inhibitors. The mechanism of action of protein synthesis inhibitors involves targeting the bacterial ribosome, a critical component in the protein synthesis pathway. These antibiotics disrupt the process of protein synthesis in various ways, leading to the inhibition of bacterial growth or death. Here's how each group operates. In aminoglycosides, it binds irreversibly to the 30S subunit of the bacterial ribosome. This binding leads to misreading of the mRNA by the ribosome, preventing the correct transfer of peptidyl tRNA from the A site to the P site. Consequently, it hampers the elongation of the polypeptide chain, disrupting protein synthesis. In case of tetracycline, it reversibly binds to the 30S subunit of the ribosome. By binding to the 30S subunit, tetracyclines prevent the attachment of amino acid tRNA to the ribosome's mRNA complex, inhibiting protein synthesis. This action blocks the addition of new amino acids to the growing peptide chain. In chloramphenicol, it binds irreversibly to the 50S subunit of the ribosome. This binding inhibits the peptidyl transferase activity of the ribosome, blocking the transfer of the growing peptide chain from the P site to the newly attached amino acid tRNA at the A site. This action effectively halts protein synthesis by preventing the elongation of the polypeptide chain. Next, in lincosamides, it inhibits the peptidyl transferase enzyme by acting on the 50S subunit, similar to the chloramphenicol. They inhibit the early stages of protein synthesis, preventing the elongation of the protein chain. This results in the inhibition of bacterial growth and replication. Next is the macrolides. Macrolides reversibly bind to the 50S subunit of the bacterial ribosome. By inhibiting the peptidyl transferase enzyme, macrolides prevent the elongation of the peptide chain during protein synthesis. Macrolides also interfere with the transfer of the peptidyl tRNA from the A site to the P site of the ribosome, further impeding the elongation of the peptide chain. Additionally, macrolides inhibit the translocation of the ribosome along the mRNA molecule. This immobilizes the ribosome, preventing it from moving to the next codons on the mRNA strand and inhibiting further protein synthesis. And lastly, oxazolidinones. Linezolid, a representative of oxazolidinones, binds to the 50S subunit of the bacterial ribosomes. By binding to the 50S subunit, linezolid prevents its interaction with the initiation complex, which is crucial for the initiation of protein synthesis. This inhibition ultimately halts the initiation of protein synthesis, leading to bacterial growth inhibition and death. Let's start with the aminoglycosides. Aminoglycosides are a group of natural and semi-synthetic antibiotics discovered because of systematic search for drug active against gram-negative organisms. Aminoglycosides are antibiotics with amino sugars joined by glycosidic linkages. They are derived from soil actinomycetes of the genus Streptomyces and the genus Micromonosperma. Amikacin and netilmicin are examples of semi-synthetic aminoglycosides synthesized through chemical modification of natural compounds to enhance their pharmacological properties. Also, streptomycin gained prominence due to its efficacy against tubercle bacilli, marking a significant milestone in the treatment of tuberculosis. Derived from Micromonospora purpurea, gentamicin is another potent member of the aminoglycoside family widely used in clinical practice. Beside aminoglycosides, there exist related compounds known as aminocyclitols, where the amino group is attached to the cyclitol rather than a sugar ring. Examples include spectinomycin and apramycin. Aminoglycosides are classified into different categories based on their antibacterial spectrum, highlighting their effectiveness against specific groups of bacteria. In narrow spectrum, example includes streptomycin and dihydrostreptomycin. In extended spectrum, it includes neomycin, flamicetin, paromomycin, and kanamycin. In broad spectrum, it includes gentamicin, tobramycin, amikacin, sisomycin, and netilmicin. In miscellaneous, it includes aparamycin and spectinomycin. These drugs are structurally somewhat different from typical aminoglycosides, but have similar antibacterial spectra and mechanism of action. Next is the sources of these aminoglycosides. Streptomycin from Streptomyces griseus, neomycin from Streptomyces fradii, kanamycin from Streptomyces kanamyceticus, gentamicin from Micromonospora purpurea, bromycin from Streptomyces tenebrarius, amikacin from semisynthetic derivative of kanamycin, isomycin from Micromonospora inuensis, netilmicin from semisynthetic derivative of isomycin, and flamicetin from Streptomyces lavandulae. Next is the mechanism of action of aminoglycosides. Aminoglycosides, being water-soluble, penetrate the bacterial cell membrane through aqueous pores and reach the periplasmic spaces. They are also taken up and transported across the cell membrane into the cytoplasm by an oxygen-dependent active transport process. It is observed that aminoglycosides disrupt the bacterial cell membrane, and this allows penetration of the drug into the bacterium from the periplasmic space. Inside the cell, aminoglycosides bind to the 30S ribosomes and inhibit bacterial protein synthesis. These block initiation of protein synthesis, cause termination of protein synthesis, and cause addition of incorrect amino acids, resulting in the synthesis of abnormal protein. Aminoglycosides are also bactericidal. The higher the concentration, the greater is the bactericidal effect. The residual bactericidal effect or the post-antibiotic effect remains even after the plasma levels of aminoglycosides fall. Hence, even though they have short half-life, they can be given even once a day. The low extracellular pH and anaerobic environment inhibit the uptake of aminoglycosides by active transport because this is an oxygen-dependent process. Hence, aminoglycosides are not effective against anaerobic infections. And drugs acting on cell wall like penicillin counter this negative effect of low pH and anaerobiasis and improve penetration.
Aminoglycosides penetrate the bacterial cell membrane through passive diffusion and pore-in channels. Once they reach the periplasmic space, aminoglycosides bind irreversibly to the 30S ribosomal subunit of the bacterial ribosome. This binding interferes with the proofreading process during protein synthesis. Aminoglycosides cause misreading of the mRNA or messenger RNA template during translation. This leads to the incorporation of incorrect amino acids into the growing polypeptide chain. The biphasic mode of killing of aminoglycosides refers to the observation that these antibiotics exhibit two distinct phases of bactericidal activity against bacteria. At low concentrations, Aminoglycosides primarily exert their bacterial effect through concentration-dependent killing. In this phase, the rate and extent of bacterial killing increase as the concentration of antibiotic increases. Initial rapid killing is followed by late slow killing. Those that survive initial killing become resistant to late phase because of decrease in permeability. Administration of antibiotic during refractory period enhances toxicity. Bacteria can produce enzymes such as aminoglycoside inactivating enzymes, which chemically modify the aminoglycoside antibiotic. These modifications can include acetylation, phosphorylation, or adenylation of specific sites on the antibiotic molecule, reducing its affinity for the bacterial ribosome and rendering it ineffective. It has poor oral absorption, low volume of distribution, has a short half-life, and is excreted in the urine. Aminoglycosides has an additive effect if administered together with a beta-lactam. When aminoglycosides and sulfonamides are used together, they can increase the risk of certain side effects, including gastrointestinal issues such as enteritis. Aminoglycosides can produce toxic effects, particularly when administered at high doses or for prolonged periods. Here is a list of the main toxicities that aminoglycosides produce. Here is another list that contains precautions one needs to understand before using aminoglycosides. For example, avoid concurrent use of other ototoxic drugs like loop diuretics. Here is a summary on what we discussed about aminoglycosides. It includes the route of administration, pharmacokinetics, mechanism of action, its uses, and adverse effects. Now let's talk about tetracycline. It is a group of natural and semi-synthetic antibiotics having nucleus of 4 cyclic rings in their structure. It is actually obtained from bacteria. Chlortetracycline was the first tetracycline to be obtained from Streptomyces aureofaciens. Tetracyclines are broad-spectrum antibiotics with similar antimicrobial features, but they differ somewhat from one another in terms of their spectrum and pharmacokinetic disposition. There are 3 naturally occurring tetracyclines, which are oxytetracycline, chlortetracycline, and dimethylchlortetracycline. There are also semi-synthetic tetracyclines. Tetracyclines can also be classified through their elimination time. Some are short-acting, intermediate-acting, and long-acting. Natural tetracyclines are antibiotics that are directly isolated from microorganisms in nature, particularly certain species of Streptomyces bacteria. Semi-synthetic tetracyclines are modifications of the natural tetracycline structure made through chemical synthesis or semi-synthetic processes. These modifications are designed to improve pharmacokinetic properties, enhance antibacterial activity, or reduce side effects compared to their natural counterparts. Short-acting tetracyclines have a relatively rapid onset of action and a shorter duration of activity compared to other formulations. Intermediate-acting tetracyclines have a longer duration of action compared to short-acting formulations, but may still require multiple daily doses for optimal therapeutic effect. Long-acting tetracyclines, on the other hand, have the longest duration of action among tetracycline formulations, allowing for less frequent dosing intervals. Tetracyclines exert their antimicrobial effects primarily through inhibition of bacterial protein synthesis. They bind reversely to the 30S ribosomal subunit, preventing the attachment of amino-acyl tRNA to the mRNA ribosome complex. Tetracyclines are also bacteriostatic rather than bactericidal. Here is a visual representation of the mechanism of action of tetracyclines. Resistance to tetracyclines is transmitted by plasmids that contain the genes coding for resistance. Moreover, the organism may easily develop resistance to many other antibiotics because the genes that control the resistance to tetracyclines also influence the resistance to many other antibiotics. Tetracyclines are about equally active and typically have about the same broad spectrum, which comprises both of aerobic and anaerobic gram-positive and gram-negative bacteria. Tetracyclines are incompletely absorbed in the gastrointestinal tract, with their absorption being influenced by various factors such as food, calcium, and certain medications. Other tetracyclines have lower bioavailability compared to newer ones. Tetracyclines distribute widely through the body, reaching various tissues and bodily fluids. They can penetrate tissues such as the blood-brain barrier, and distribution is affected by protein binding. The biotransformation of tetracyclines primarily occur in the liver, where these antibiotics undergo various metabolic processes before they are eliminated from the body. The exact pathways of biotransformation can vary depending on the specific tetracycline compound. Tetracyclines are primarily eliminated via the kidneys, both through glomerular filtration and the GI tract. The plasma half-lives of tetracyclines are 6 to 12 hours, and even longer depending on age, disease, and the tetracycline itself. The pharmacokinetic values also vary based on its classification and species. Tetracyclines usually are administered orally. Here is a table that contains the elimination, distribution, and clearance of tetracyclines. Tetracyclines are versatile antibiotics used to treat a wide range of systemic and local infections. They are also effective against specific diseases. Beyond antimicrobial therapy, tetracyclines also have other effects such as growth promoters, tumor deniation, and medical treatments like inhibiting antidiuretic hormone action and aiding tendon stretching in neonatal foals. Here's a table that contains the specific dose rates of specific tetracyclines. Because several diverse effects may result from the administration of tetracyclines, caution should be exercised. The side effects of tetracyclines are superinfection, gastrointestinal disturbance, disruption of gut microflora, and effects on teeth, bones, and cardiovascular system. It can also cause toxicity, such as hepatotoxicity, nephrotoxicity, phototoxicity, hypersensitive reactions, and renal toxicity. The next drug that we will be discussing is chloramphenicol. It is a broad-spectrum antibiotic, first obtained from a bacteria known as Streptomyces venezuelae. It is the first antibiotic to be chemically synthesized for clinical use. It is a derivative of dichloroacetic acid and it contains a nitrobenzene moiety, which is responsible for its antimicrobial activity. It is a bacteriostatic drug. It interferes with protein synthesis and is an irreversible inhibitor of 50S ribosome. It inhibits the peptidyl transferase enzyme, thereby preventing the amino acid transfer for growing polypeptide chains. It also inhibits mitochondrial protein synthesis in mammalian bone marrow cells in a dose-dependent manner. Here is a visual representation of antibiotic drugs. As you can see, chloramphenicol is located together with other 50S inhibitors. For its antimicrobial spectrum, it is a broad-spectrum drug. It inhibits gram-positive, gram-negative, aerobes, and specific microbes like Salmonella. It also has less action against gram-positive cocci. Chloramphenicol comes in tablet form, capsules, as a liquid suspension, and in an injectable form. Tablets, capsules, and liquid suspensions should be given by mouth with food. Chloramphenicol is widely distributed throughout the body fluids and tissues. including the cerebrospinal fluid. Chloramphenicol is primarily metabolized in the liver by glucuronidation. It is excreted in the urine primarily as inactive glucuronide conjugates. It should not be combined with drugs, especially in immunocompromised patients. Also, it should not be combined with penicillin G and other 50S inhibitors since it will produce an antagonistic effect. Depending on the dose, it can suppress the bone marrow, but in higher doses, it can depress the bone marrow. For its clinical application, it is used for both local and systemic infections in animals. Here is a table with the doses of chloramphenicol. As you can see, the dose and half-life depends on the species. Thiamphenicol is a synthetic derivative of chloramphenicol, developed to overcome some of the limitations associated with chloramphenicol use, such as bone marrow suppression. Fluorphenicol is a fluorinated derivative of thiamphenicol, designed to enhance its pharmacokinetic properties and broaden its spectrum of activity. Aside from the differences listed here, while chloramphenicol and thiamphenicol share some similarities, thiamphenicol has been developed as a safer alternative with a potentially reduced risk of serious adverse effects, particularly bone marrow suppression. Now let's talk about macrolides. These are antibiotics characterized by macrocyclic lactone ring attached to two or more deoxysugar moieties. Macrolides can be divided into two. Class 1, those that have a 14-membered ring, and Class 2, those that have a 16-membered ring. This group is similar to penicillin but has a wider spectrum of activity. This also means that you can use macrolides in animals that are allergic to penicillin. Some members of macrolides are also used in treatment of tuberculosis in man. The prototype drug of this group is erythromycin. It comes from the bacteria Streptomyces erythraeus. Enterobacteriaceae and Pseudomonas are resistant bacteria to erythromycin. Avoid using this drug if you are using other 50S binders and other macrolides. Erythromycin is mainly effective against most aerobic and anaerobic gram-positive bacteria, but in general, macrolides have a narrow spectrum and is not effective against gram-negative bacteria. Bacteria can mutate the structure of the ribosomes, which are the targets for erythromycin. These changes prevent the antibiotic from binding properly, rendering it ineffective. Bacteria can also acquire resistance genes from other bacteria through a process called horizontal gene transfer. This allows them to gain resistance mechanisms even if they did not develop the mechanisms themselves. Erythromycin is bacteriostatic at low and bactericidal at high concentration. It is a 50S inhibitor. Like other 50S inhibitors, macrolides bind to the 50S ribosome, which is used by the bacteria for translocation of growing polypeptide chains from A site to the P site. Without this ribosome, protein synthesis is inhibited. Erythromycin base is highly susceptible to degradation by gastric acid. This is why an enteric coating is required when it is administered orally. It is well distributed in all tissues, metabolized in the liver, and excreted mainly through the urine and bile. You should be careful when administering macrolides. Their toxicity and adverse effects are based on the route of administration, dose, and species. It should not be given to animals with pre-existing liver disease. It is the drug of choice to treat and prevent diarrhea and abortion caused by Campylobacter jejuni. It is also used for penicillin-allergic animals and many more. Both roxithromycin and clarithromycin is longer-acting, acid-stable, and better absorbed compared to erythromycin. Roxithromycin should be taken 30 minutes before food intake since food can affect its absorption and bioavailability, while clarithromycin has a lot more similarity to erythromycin. Azithromycin is an azalide derivative of erythromycin with similar activity to clarithromycin. It is free of drug interactions and is used in prophylaxis and treatment of atypical mycobacterial infections in AIDS patients. Oleandromycin, troleandromycin, and spiramycin are all similar in antibacterial activity. However, they differ from their sources. Oleandromycin and troleandromycin are both from Streptomyces antibioticus, while spiramycin is from Streptomyces ambofaciens. Tylosin is another macrolide that is administered through subcutaneous injection or in drinking water or in feed. Its antibacterial spectrum is similar to erythromycin and is obtained from a strain of Streptomyces fradiae. Lincosamides closely resemble macrolide antibiotics in their antibacterial spectrum, mechanism of action, and clinical application. This means they work by inhibiting bacterial protein synthesis, thereby stopping the growth and reproduction of bacteria. Lincosamides are derived from natural compounds produced by the bacteria Streptomyces linconensis. They are derivatives of an amino acid and a sulfur-containing octose and are also monobasic and more stable in salt forms. Bacteria can develop resistance to lincosamides through various mechanisms, including plasmid-mediated resistance and cross-resistance. Plasmid-mediated resistance refers to the acquisition of resistance genes carried on plasmids, which are small, circular DNA molecules separate from the bacterial chromosome. Cross-resistance refers to the phenomenon where bacteria develop resistance to one antibiotic, which also confers resistance to other antibiotics due to shared mechanism of action. In the case of lincosamides, bacteria can develop cross-resistance to other antibiotics that target the bacterial ribosome. Lincosamides have a broad spectrum of antimicrobial activity against various bacteria, both gram-positive and gram-negative, as well as some anaerobic bacteria. However, their spectrum of activity is narrower compared to some other classes of antibiotics like fluoroquinones or third-generation cephalosporins. Lincosamides are widely active against gram-positive bacteria and most anaerobes, but not gram-negative aerobes. They can be administered orally or through intramuscular or intravenous injections. Lincomycin is incompletely absorbed in the GI tract, especially if administered soon after feeding. Plasma levels peak in 1 to 2 hours. About 90% of an oral dose of clindamycin is absorbed, and effective plasma concentrations are achieved more rapidly than with lincomycin. Clindamycin palmitate is administered orally, while clindamycin phosphate is administered through intramuscular injection. Lincosamides are widely distributed in many fluids and tissues, including bone, except cerebrospinal fluid. They diffuse across the placenta in many species, and about 90% of clindamycin is bound to plasma proteins. After administration orally, approximately 50% of a dose of lincomycin and 80 to 90% of a dose of clindamycin are metabolically altered in the liver. It should be noted that liver disease impairs the biotransformation of lincosamides. Unchanged antibiotic and several metabolites may be excreted in bile and urine. The proportions depend on the route of administration. It should be noted that milk is also an important excretory route. No serious organ toxicity has been reported, but GI disturbances do occur. Lincosamides are contraindicated in horses because severe and even fatal colitis may develop. Skeletal muscle paralysis may be seen at high concentrations. Lincosamides should also not be used in neonates because of their limited ability to metabolize drugs. Lincosamides have additive neuromuscular effects with anesthetic agents and skeletal muscle relaxants. Kaolin pectin, which is an adsorbent, prevents their absorption from the GI tract. They should not be combined with bactericidal agents or with the macrolides since it can cause an antagonistic effect. The lincosamides are indicated for infections caused by susceptible gram-positive organisms, particularly streptococci and staphylococci, and for those caused by anaerobic pathogens. Clindamycin may be used in treating pneumocystis carinii infection in combination with primaquine. As you can see, it also has different uses depending on the species. Clindamycin is a semisynthetic derivative of lincomycin and differs chemically from lincomycin by substitution of a chloride atom for a hydroxyl group. It is more potent than the parent compound. Absorption is better than lincomycin and has reduced incidence of adverse effect than lincomycin. Now let's talk about peptide antibiotics. Peptide antibiotics are a class of antimicrobial peptides produced naturally by various organisms, including animals, plants, fungi, and bacteria. These peptides play a crucial role in the innate immune response, helping to defend against bacterial, viral, and fungal infections. Peptide antibiotics typically have a broad spectrum of activity, meaning they can target a wide range of pathogens. First, we have polymyxins. Of this group of peptide antibiotics, polymyxin B, which is sourced from Bacillus polymyxa, and polymyxin E or colistin, which is sourced from Bacillus colistinus, are most commonly used topically and orally. The mechanism of action of polymyxins involve disrupting the integrity of bacterial cell membranes, leading to cell death. This mechanism differs from many other classes of antibiotics, which typically target intracellular processes such as protein synthesis or cell wall synthesis. They competitively bind with calcium and magnesium. This interaction in the cell membrane disrupts the bacteria's permeability and function. As a result, ions and amino acids leak out and the cells die. Polymyxins are effective against gram-negative bacteria and ineffective against gram-positive bacteria. They also have a narrow spectrum of activity. Although intrinsic bacterial resistance to polymyxins is recognized, resistance is generally uncommon and is chromosome-dependent only. Polymyxins act synergistically when combined with potentiated sulfonamides, tetracyclines, and some other antibacterials. Their action is inhibited by divalent cations since they can compete with polymyxin binding to the cell membrane. Unsaturated fatty acids and quaternary ammonium compounds can also inhibit polymyxins since they can form complexes that may prevent polymyxin to bind to the cell membrane. Polymyxins are not absorbed after oral or topical administration and do not cross the blood-brain barrier. For systemic effects, they are administered parenterally. Blood levels usually are low because polymyxins bind to cell membranes, as well as tissue debris and purulent exudates. The polymyxins undergo renal elimination, mostly as degradation products, and their plasma half-lives are 3 to 6 hours. It should be noted that polymyxins are nephrotoxic and neurotoxic. Intense pain at sites of injection and hypersensitivity reactions also can be expected if using polymyxins. The main indication for parenteral use of polymyxins is life-threatening infection due to gram-negative bacilli or Pseudomonas species that are resistant to other drugs. Polymyxins are also used orally against susceptible intestinal infections, and topical application is a common usage of this antibiotic. Here are other peptide antibiotics which are not discussed in detail.